today's topic is aptly orthobiologics of the knee. So I think first and foremost, it's really important that whenever talks about orthobiologics, you have to disclose if you have any relevant disclosures. And thankfully, I have none for this particular talk. So orthobiologics in the knee, and I think we need to answer 4 questions. What is it that I currently use? What are the products that I can use? What are the products that I may be able to use? And what I am looking forward to use? And I think it's pretty relevant that we answer all these 4 questions because it really sets the tone for things to come in the next decade or two. So broadly, you can classify orthobiologics into autologous products and allogenic products. If you look at the autologous products, essentially you have chondrocytes, you have PRP in its various forms, either leukocyte rich or poor. You can have bone marrow aspirate with or without additional stimulation like Neupogen. You can use adipose tissue either in the form of vascular stromal factor or the mesenchymal cells. And you can also have various formation of autologous conditioned serum, which could be either based upon the particular lab or they could be at the point of care, so as to say. The allogenic orthobiologic products that we have available are the various tissue-specific MSCs. You have the amniotic line of products, especially with the amniotic stem cells or the various amniotic fluid products. And last but not the least, you have the various scaffolds, which will consist of either a micronized or minced chondral tissue, and you could have chondral and osteochondral discs. So essentially, it's not going to be possible for me to touch or discuss each and every one of them, but I probably picked up few which I felt were important, especially in the Indian scenario, which could have relevance in our day-to-day clinical practice. So these orthobiologics essentially will work in 3 different ways. Either they're going to be useful to enhance healing, or we're going to be using them to create some kind of regeneration. And last but not the least, which is very important, is that how we can use them to modify the course of our disease. So if you look at healing, the application of healing essentially would be in ligaments, especially for the ACL or the various ligaments around the knee joint, or you could use them on the tendon in the form of various injections of PRP or BMAC, which I think have been proven quite effectively. In terms of regeneration, one can use it essentially for regenerating cartilage in the various forms of microfracture or marrow stimulation, various modalities that we have, and the improved generations of the autologous chondrocyte implantation, or we could have allograft-based products on the cartilage side. Meniscus is, I think, one area where we have to be improving in the near future. And though the current modalities of biologic augmentation such as fibrin clot are well established, I think the future is pretty promising for the newer generation orthobiologics such as MSCs, PRPs, BMAC, and certain scaffolds as well. The biggest role, I think, and the biggest application today is that of disease modification. And though in osteoarthritis, I think it's been shown to exert a good role, the role in subchondral bone yet seems to be proven. And I think that is where we need to look out for that space. So this is a very good, I think, diagrammatic representation that I picked up from this article that was published in Journal of Orthopaedic Research. And essentially, it just shows the cellular response to any form of injury or insult. And what you can see here is that it goes through 2 phases. The first phase essentially is that of cell death and inflammation. And then we have the second or the late phase, which is essentially the phase of matrix formation. In between both of these, we have the intermediate phase, which is essentially a swinging balance between the catabolic phase of tissue damage and the anabolic phase of tissue repair. And it is our capacity to use this particular modality which sets the tone as to what exactly we can use in our clinical processes. So essentially what you can have is that we can use the early phase when we're looking at cartilage lesions, when we're looking at ACL repair or early osteoarthritis, and we can use the late phase to modulate our results, especially with chronic pathologies such as tendinitis, tendinopathy, or muscle disorders in particular. So let's look at one of these one by one. If you look at articular cartilage, and what we have on the side of your screen is essentially the pyramid of evidence that we have. I think we have been shown pretty well that articular cartilage has shown all the 5 levels of evidence. We've been well established with techniques of marrow stimulation. We've been using marrow stimulation with scaffolds. There's been good evidence now that is coming out on particulate cartilage as well. ACI has evolved over the last couple of years or decades through its various phases. And definitely what seems to be really promising is the cell-based tissue culture with 3D printed scaffolds, which is something that we are all looking forward to. So it all started off essentially with scaffolds. The first scaffolds were the biphasic scaffolds, and then came the triphasic scaffolds. But unfortunately, these scaffolds did not really work too well. They did not perform as well as what cartilage wanted us to do. And I think probably the future lies on the third picture, which is there on your screen to your right. We're essentially looking at scaffolds in which we impregnate cells, and these are then transferred to the joint. So that is probably one area where one should be looking out for a good response of therapy in the days to come. Particulate cartilage is very promising. I think its most important benefit is that it is available off the shelf, so as to say. So what we have, which has been there for quite some time, is the de novo cartilage or the allogenic juvenile particulate cartilage. Unfortunately, the source of this allogenic cartilage is pretty limited. You have to have small children, who are cadaver donors, which are then amenable for this. And with the advent of the new autologous particulate cartilage now, which is now being pushed by a couple of commercially available kits, I think the results are still to be seen. They're probably still in their sort of fourth phase of evidence, where we have some amount of controlled non-randomized trials, and we still await the results with the help of PRCTs, and then later on have systemic evidence based on the same. ACI has gone through various phases of evolution. It all started off essentially by culturing chondrocytes in the lab for about 2 to 3 weeks, and then bringing them back to the operating room, essentially implanting them as an open procedure with using periosteum. Later on, it became more fancy. You had those cells that were laid on membranes, which were then just stuck down with fibrin and thrombin glue. And now I think we are quite fortunate enough to have probably the 5th generation of ACI, which is essentially a cell-based ACI technique, wherein we use cells that are suspended in a matrix of fibrin and thrombin, which tends to coagulate and form clot quite easily on the defect that has been prepared. And I think it has stood the test of time and has shown consistent results. What lies in the future, I think probably is what we are all really interested and keen about. What we really want to see is these new injectable scaffolds that are coming up. We're looking out on new marrow stimulation additives and adjuncts. So you do a standard of care procedure like a microfracture or a subchondral drilling, and then you use additives and adjuncts to improve your results, and of course the use of allogenic cells. Why does this interest us? Because these techniques are going to be point of care techniques. You're going to be having them in your operating room. They're going to be time zero. You need not send off tissue to the lab, bring it back, and then use it again. And of course, they're going to have minimal tissue trauma. We have good results now, basically, which are non-randomized controlled trials. And the use of one such product which is available, which is not unfortunately yet in the Indian market, seems to be pretty promising, which is essentially looking at alginate bead based cartilage implantation. And essentially what this is that this is a microfracture or a subchondral drilling, essentially a marrow stimulation procedure in which the clot is stabilized with the help of a matrix that consists of fibrin as well as chitosan, which sets as early as about 15 minutes in the operating room, takes less than 15 minutes to prepare. And probably this could be a very good opportunity for all of us to look into. We have good data. We've got level 4 evidence with, we've got the fourth pyramid level of evidence with randomized controlled trials. And I think we still need more data on the same. Looking at ACL, I think on ACLs, we still are having a futuristic view as regards orthobiologics are concerned. And two main areas where we are having focus now essentially are the use of scaffolds and also the use of growth factors. The BEAR technique, or the bridge enhanced ACL repair technique, is now in its second trial stage. In this, you essentially put sutures in the ACL and the ACL is sutured back. And the only difference here is that this suturing is done in the sort of in the milieu of a collagen-based scaffold, which is infused with the patient's own blood. So essentially what we do is put stitches in the ACL, we try and repair a mid-substance tear, and we enclose or encapsulate that repair in a collagen scaffold, which is infused with the patient's own cells. And the second trial, which is on in Martha Murray's group from out of Boston, is showing very good, encouraging results with less than 4% failures. Of course, this is yet out to be there for commercial use, and it is now undergoing its third trial phase, so as to say. The other interesting part is that the use of growth factors. And now comes this very interesting study group with one out of Poland, out of Conrad's group, and the second one which is coming out of Switzerland, Rolly Jacobs group, as well as Daniel Saris's group from Netherlands. And essentially what they're looking at is that they're looking at the bioactive tapes. So you're essentially doing an ACL repair, doing some kind of an internal brace, and then this tape is combined with bone morphogenic protein 2 to make it biologically active. And they have shown in rabbit studies that this is accelerating healing after doing ACL deconstruction. And probably this is something where future might look forward to. So a lot of interesting things happening on the ACL side. Essentially, the ACL will behave differently since it is completely intra-articular, intrasynovial, and it lacks the, if I can say, it lacks the facility or it lacks the healing capacity of the MCL, especially because there is no blood clot that is formed. On the meniscus side, the time-tested techniques of biological stimulation have proved the test of time, but however, still there is an increased need or a requirement for betterment of results, because no matter what you do, your meniscus repairs, they will heal only 60 to 70% of times. 30 to 40% of the menisci will still not heal, and we are still not good as what we should be, essentially because there is a big gap that is left between healing rates and the surgical technique, and there is something that requires to be bridging this gap. Scaffolds, contained BMAC and PRP, and probably cell-based tissue culture with 3D printable scaffolds are something that we need to look into. So if you look at stimulation, the use of stimulation either by the use of rasping, trephinition, microfracture, or fibrin clots has shown to improve the rates of healing by about 10 to 15%. And I think now these have formed a standard of care in our clinical practice. Whenever we are doing any form of meniscus repair, these techniques have become a standard of care, so as to say. Scaffolds came in with a lot of good promise. Their whole essence was that we are using either a collagen or a polyurethane scaffold, and this was sutured into a defect. But look at the picture in the center of your screen. This shows you that essentially you need a segmental defect, and it is very, very uncommon to have a segmental defect within a meniscus and where this scaffold will actually fit. And no matter what you do, 10 to 30% of these scaffolds will fail at the end of 5 to 7 years, which still makes it a technique that requires definite more research and more looking into. PRP and BMAC, which are injected intra-articularly, I think we don't have any data on simple BMAC injections inside the joint per se and their influence on meniscal healing. We have two studies on intra-articular injections of PRP. Essentially, the recent most study showed that it was comparable to whether you used or did not use PRP injection, and this was done in meniscus lateral discoid meniscus tears. Another study from 2018 did show that PRP injected knees had marginally better healing rates on MRI scans than non-PRP injected knees. But I think this is too small a data for us to digest and assimilate in our clinical practice to understand what we should be doing. What really seems to be very interesting and fascinating are the PRP BMAC wraps. So essentially, what you end up doing is that you do a proper meniscus repair, and then you take a membrane like chondroguide and you wrap this chondroguide membrane over your repair. So just as say you were making say a kathi kebab roll or a frankie, you put the meat in and then you wrap the kebab, you can wrap the roll over it. Similarly, in these type of repairs, you do the repair and then you put a chondroguide wrap over it and then you inject BMAC within it. As interesting and as attractive as it sounds, this is extremely difficult, I think, for most average surgeons like myself to do, to try and repair a meniscus first and then to get a wrap that goes on it, tack it in, and then again try and inject in between the same seems to be really technically challenging. There have been 2 papers which have shown that almost about 3/4 of menisci treated with such technique have got no retears on MRI scans, but still I think the technical challenges with this procedure still preclude it from the use of the common public, so as to say. What is really interesting now, when we have the lowest evidence for human clinical use, is the use of cell-based scaffolds. So just like for cartilage, we would love to have scaffolds impregnated with cells. Here we can go to the lab, have a 3D print of your meniscus on a scaffold, and then have it sent off to us and then have it in. But I think it is still at least a decade away from good ethical clinical use for us to really understand its benefits. Looking on to the role in subchondral bone and early osteoarthritis, I think essentially here we look at a lot of injections that are used in early OA. They can be both autologous as well as allogenic. And then we also have various scaffolds and substitutes that we can use in our clinical practice. Subchondral bone probably was one of the earliest and most promising technologies that we really looked forward to. And it has been very well documented that subchondral bone is the soil on which the seed of the cartilage is laid. So if you have poor quality subchondral bone, your cartilage over that is likely to fail. And this is what is one of my own patients who had a failure of his cartilage following an ACI procedure, in which what you can demonstrate is that the whole cartilage just flaked off over a period of time because the subchondral bone was essentially bad, and that is what happens. So various techniques to try and improve the quality of subchondral bone by injecting PRP, by injecting BMAC, with a substrate such as hydroxyapatite have been tried, but still they are probably at the best with current evidence only a temporizing modality. These patients will do good for a year or two, and then they come back and they fail again. So probably your subchondral bone techniques or subchondral bone plasty or subchondroplasty may not prevent progression of the disease, which is something that really is still disappointing for a lot of us. Osteoarthritis, I think if you look at this fantastic article that was published by Scully in the Nature journal, it has shown that as we grow older, osteoarthritis is probably becoming a bigger and bigger problem, bigger than coronary heart disease, diabetes, or cancer or depression. And I think by 2020, as of today, it is no less than a $60 billion industry. Of course, I think the COVID has taken some of the money away from arthritis, but still it's a huge industry. And I think all the market has got its eyes on this particular arthritis issue. And all of us probably are sitting ducks for the same in the next decade or so to come. There are a variety of injections that we can use for osteoarthritis: steroids, visco, PRP, stem cells, BMAC, so on and so forth. But I think we're going to be restricting orthobiologic use to only PRP and stem cell injections for the current discussion. So currently, if one looks at the regenerative space in osteoarthritis, it is largely dominated by autologous products, whether it is fat, bone marrow, or blood. The use of allogenics in the form of amniotic tissue fluid was in vogue, but however, the easy availability and reproducibility with the autologous products has led to less dominance and less popularization of the allogenic products. Yes, these are of use in grade 2 and grade 3. You should not use them in grade 4. Grade 3 is somewhat of controversy, but in grade 1 and grade 2, they have shown to have decent beneficial effects. So the 4 questions for osteoarthritis that one needs to answer is that how does it work? Is it effective? In whom will it be effective and when will it be effective? And of course, the last question that I want to answer is it going to be cost effective? So platelet-rich plasma, I think, probably has been the most popular studied orthobiologic in the use of osteoarthritis. Platelets do comprise, plasma does comprise about 55% of your normal blood. And these platelets, when they express, they will reach out to the cartilage in more than one ways. So this platelet PRP that you're going to be using and going to be injecting is going to essentially exert its effects by stimulating cells of the cartilage, synovium as well as the ACL. It is also going to enhance what is called as the SZP, or the superficial zone protein secretion, which essentially protects your cartilage. And this, both of these are going to decrease the friction coefficient, which is where you have the main beneficial effect of PRP as far as osteoarthritis is concerned. Mohit Bhandari, who is a key founder member, and I think a great person, a great visionary, has a very fantastic web portal called My Ortho Evidence, where he gathers most and all of the current published evidence which is there, and then assimilates us for us to assimilate quite easily and sort of really digest it us down for all of us to really make it very, very, very palatable. And if you look at his website and look at various comparative modalities, I think the end conclusion that is drawn is that the whole crux is that PRP is as effective as hyaluronic acid when it comes to early osteoarthritis. And the spin-off from this now has been the use of combination of PRP with HA that is now being tried in level 2 studies as of now. And hopefully we should have a good level 1 study that comes out of the same as well. You take the HA and you mix it with the PRP, and then we use a concoction of both of them together and then inject it inside the knee, and sort of so as to have the best of both worlds. Mesenchymal stem cells, or MSCs as we know them, I think the credit goes to Arnold Kaplan way back when he published about them in 1991. And the whole mesenchymal stem cell has been shown to sort of mature or proliferate into different cell lines and different cell lineages based on the kind of stimulus that it receives. So what was really important for all of us to understand is that the use, or if I can say misuse, of these MSCs led to a completely new change or paradigm shift into looking at what they were. And now MSCs are no longer known as mesenchymal stem cells, but actually they have now been relabeled as medicinal signaling cells. So they are not the cells that will differentiate, but they are the cells that will signal the change of a particular cell lineage. And I think today we should look upon them and understand that MSCs are no longer mesenchymal stem cells. They are not stem per se, but they are really medicinal signaling cells. How do they work? They work by recruiting other stem cells, which is really important. They will secrete bioactive factors like the angiogenesis factor or the mitosis or the anti-apoptotic factor, and they will cause local modulation by doing through the anti-inflammatory properties and by different immunomodulatory properties as well. So adipose tissue is one such important medicinal signaling cell. Of course, it is more commonly seen, and you have higher concentrations of adipose of these cells in adipose tissue, more than bone marrow and more than blood. And of course, it leads itself to minimally invasive harvest, and that's why adipose tissue probably is going popular in this MSC bracket. And of course, a person like me is happy to donate fat anytime that you ask upon it. So if you look at the various yield sources of MSCs, and you have on your left bone marrow, adipose tissue, umbilical cord, synovial fluid, etc., you'll find that adipose tissue will yield the highest number of colony forming units and the highest frequency range of MSCs, more than bone marrow aspirate, more than umbilical cord, more than synovial fluid, more than amniotic fluid, and more than peripheral blood. And that's why, as a source of MSCs, these fat or adipose cells have become extremely popular. There are various patented technologies now that are available on the market, which are using the same to sort of exert their good effects on the same. So in reality, how do these orthobiologics work? They essentially work by an anti-inflammatory action. They work by synovial restoration and cellular stimulation. Is it effective? Yes, the meta-analysis do show that all of these are effective. In whom are they effective? I think grade 1 to grade 3 is the person that you should be looking out for. And is it cost effective? I think that is your personal judgment, because these don't come cheap. They come at a price, and that is what we need to look into. So I think to conclude, orthobiologics are important. We are driven by the need of biology, because the biological modulation is going to be the future, especially if you're trying to modify disease or if you're trying to heal or repair tissue inside the joint. And it's really important that we attack at that early stage and not come in at that late stage, which will really make the difference. It is definitely hampered today because of regulatory processes. Now regulatory processes are getting stricter and stricter, and we don't want to be using our patients as guinea pigs or as test bunnies, so as to say. And these regulatory processes are actually sort of influencing people to start doing these various products under the table, which is something which is not too good. You have also the dirty truth. A lot of money is involved in all of these orthobiologics. We don't want to use our patients as guinea pigs without ever actually discussing this with them. And though it is not illegal to use orthobiologics, of course, there is also a question of ethics. Is it ethically questionable or not, is something that we need to answer. If you have a mixed economy where there is demand as well as market, sometimes you have to be careful, otherwise market-driven forces will just carry you away. I will request all of you to read this open access article, which is published in the Journal of the WOS last year, January, in which you have the consensus meeting of the NIH and the 2018 WOS. And this leads to a lot of good statutory guidelines that have been laid down, especially for the use of osteoarthritis and its use of orthobiologics. And this is completely open access, so feel free to download it and read it. It's, I think, a very good read. So orthobiologics, yes, doing really well for cartilage repair. Yes, it is doing well for ACL repair, but it is not yet ready for clinical use. Meniscal healing, I think we'd love to have it. That's where we really want it to happen, but it's not yet proven, and still there's a gap that needs to be filled. Subchondral bone, it's been a disappointment, so as to say. Osteoarthritis, I think it's doing really good. So I definitely want to sort of end up by giving the following messages. You might feel that I'm pessimistic, but I think it's really important. One is that do not advertise that orthobiologics are magic. They're definitely temporizing procedures, but still the jury is not out as yet. It is important as a responsible clinician that you should discuss the advantages, drawbacks, and limitations of the orthobiologic that you propose to use in your own clinical patient. You have to be critical in your judgment. It's really important to sort of pick and choose the right things, so as to say. The use of an orthobiologic is not going to improve a poorly done procedure. So if you do a poor meniscus repair and expect that your orthobiology is going to heal it, it's not going to happen so. And definitely don't throw time-tested technology out of the door. It's important to understand and realize the good results that we are still getting with the time-tested technology. So friends, thank you so much for this first SCI webinar. And I hope it was useful. I enjoyed talking to a lot of you. Stay safe, stay home, and stay secure. And thank you so very much for allowing me to present my views on orthobiologics. Thank you so much.